Lots of buzzwords that we have to memorize for congenital cardiac defect associations. Let's go ahead and get started. Now, exposure to ethanol in utero can result in cardiac birth defects, and they usually occur along with other classical physical exam findings. Now, ethanol exposure leads to fetal alcohol syndrome. The classic cardiac problems are usually a VSD, a PDA, or an ASD, and even potentially tetralogy of Fallot. So how are they going to present this patient to you? They're going to tell you that they have fetal alcohol syndrome? No. You're going to get a description of the physical findings seen in FAS. So the facial dysmorphisms of short palpebral fissures, a thin upper lip, a smooth philtrum, in combination with a decrease in growth and CNS abnormalities are exactly what you should think about when recalling fetal alcohol syndrome. Now let's move on to rubella. Congenital rubella is due to a viral infection of endothelial cells and vascular smooth muscle cells and cardiomyocytes. These are all within the developing heart because the infant is exposed to rubella hematogenously through the mother. So infected vascular smooth muscle cells, infected endothelial cells cannot perforate to close the septa or the ductus arteriosus. What does this do? We get defects associated with improper closure of structures. So we can get ASDs, we can get VSDs, and we can get persistent ductus arteriosus later on. A very high yield thing to know is that pulmonary artery stenosis can also occur in conjunction with all these other physical exam findings when an infant is exposed to rubella in utero. Now on to a big one, Down syndrome. Down syndrome has a strong association with endocardial cushion defects because the region of chromosome 21 codes for an important cell adhesion molecule that is key in the development of the heart. Without this properly functioning cell adhesion molecule, these endocardial cushions do not fuse correctly with each other. In the embryology section, you learned that the endocardial cushions have to fuse with each other to help in the formation of atrial and ventricular septa. Now, if these endocardial cushions are not functioning correctly, then you're going to have defects because you cannot appropriately separate chambers. What kind of defects are you going to have? You could have an atrioventricular canal defect, an ASD, or VSDs. I remember a question on step 1 asking for the most common heart defect in Down syndrome or trisomy 21. What's the answer? Endocardial cushion defects. Extremely high yield. You have to know what's the most common thing so that you can be on the lookout for the most common thing. Now, an infant born to a diabetic mother is predisposed for what? Transposition of the great vessels. Why? High levels of glucose are very, very dangerous. They interfere with normal cell signaling, particularly in the cell signaling of the aorticopulmonary septum and the neural crest cells in that area. Can you tell me another congenital anomaly associated with maternal diabetes that involves the spine? How about caudal regression syndrome? Remember, caudal regression syndrome is a condition in which the lumbar spine, the sacrum, and the coccyx do not form properly. This also occurs in combination with hypoplasia of the lower extremities. Now what about our Marfan syndrome? We know this, right? We better know it because it ties in cardiology with biochemistry. The classic cardiac manifestations of Marfan syndrome are mitral valve prolapse, weakening of the aortic root with a potential for aortic root dilatation. So here's our aortic valve, and the roots can be pulled apart, leading to aortic root dilatation and subsequent regurgitation, leading to aortic regurg. More importantly, because it's very dangerous, is that these patients have weak vessel walls. So here's our aortic arch, here's our aortic valve. The high pressures in the aorta predispose Marfan patients to aneurysmal dilations because they have very weak, disorganized connective tissue within the arterial wall. Marfan syndrome, big time association with mitral valve prolapse, aortic aneurysms and also aortic dissection. Now, what about lithium exposure? When you think lithium, think Epstein anomaly. Do not be looking for this eponym. The question is going to describe the cardiac findings. So we know from embryology that the tricuspid valve forms from the fused endocardial cushions of the AV or atrioventricular canal. The problem in Epstein anomaly is that the valves do not finish separating from the endocardial cushions that they come from. They literally remain stuck in the right ventricle. This makes it look like the right atrium is extending down into the right ventricle. This is the term atrialized right ventricle that gets tossed around a lot. The main problem in Epstein anomaly is that the tricuspid valve is tethered down into the right ventricle and it cannot finish completely separating the right atrium and the right ventricle, and therefore it looks like the right atrial chamber extends all the way down into the right ventricle. Classic association is with lithium exposure, so look out for mothers that have some sort of psychiatric problem that would lead them to be taking this drug. Now again, here comes Turner syndrome. One more time, extremely high yield syndrome for your step 1 exam. It is classically associated with a bicuspid aortic valve and coarctation. Now, what cardiac anomaly would you expect to be asked about in a kid with Williams syndrome? So people with Williams syndrome have a deletion in elastin. This leads to a very constricted and stenotic aorta directly above the aortic valve. So here is our aortic valve leaflets, and they have supravalvular constriction. So this area here is very narrow. You will have to remember that Williams syndrome patients have supravalvular aortic stenosis for the rest of your life. You're always going to be asked about it, and it's going to be on all of your step exams. Now let's move on to the 22q11 syndromes. So chromosome 22 has a long arm denoted by Q. The number 1 indicates that this is region 1, and the second one tells us that it is in band 1. Deletions in this area of your chromosome 22 are bad. They are really bad because this area of chromosome 22 codes for an important transcription factor that is crucial in the signaling between the endoderm, mesoderm, and the neural crest cells that are part of the pharyngeal arch system, crucial in the development of the heart. Now, if you have abnormal neural crest cell communication with endoderm and mesoderm, what's going to happen? You usually get problems with your aorticopulmonary septum, and this makes a lot of sense why you expect to see the associations of a persistent truncus arteriosus and tetralogy of Fallot, because these pathologies are directly related to problems in the separation of the aorticopulmonary septum in the case of a persistent truncus arteriosus, and the abnormal descent of the aorticopulmonary septum in the case of tetralogy of Fallot.